Depending on the country that you are joining, the East meets West Obstetrics and Gynaecology Ultrasound Webinar Series 2021, brought to you by experts from Imperial College London. Good morning, good afternoon, and good evening. My name is Wonchol Bang, Vice President of Customer Experience Team for Samsung Healthcare. I would like to take this opportunity to express my gratitude towards Imperial College and Imperial College consultants for providing Samsung with the opportunity to work with such a prestigious institution. Also, I'm very grateful to our esteemed speakers, Professor Kandas, Dr. Almimar, Dr. Ariananda, Professor Delasta, and Mr. Yazbek. I would like to thank each of you for the tremendous efforts putting into your lectures in making it perfect. I'm deeply indebted to the moderators, Professor Bourne and Professor Lees, for making this East Meets West webinar series come to life. Without your efforts, we wouldn't have been seeing the success of bringing the latest trends in clinical practice to the audience. Most of all, I wish to express my sincere appreciation to the audience. According to the count just now, we have 1,700 people registered for this webinar, and we continue to see an increase in the need and demand for such webinars with experts. Samsung will continue to support the experts around the world so they may bring to you the latest trends and technology to meet your unmet needs in your daily practice. Thank you very much, everyone, again, and I turn the floor to our moderators, Professor Lees and Professor Bourne.
Thank you very much, and welcome to the East Meets West Obstetrics and Gynaecology webinar. This is the latest in a series which is going to be going on over the rest of the year, that's been supported by Samsung, as you've just heard. And today is, we've heard about East Meets West, but this hopefully is about gynecology meeting obstetrics, because you know, we try and look at topics that will be of interest to people who are practicing in both gynecology and obstetrics. And I think this issue surrounding caesarean section scars is one that causes problems for all of us, from those of us who treat people in early pregnancy all the way through to delivery. And we're going to try and cover that whole spectrum today. And my side of things is perhaps more focused on early pregnancy and looking at caesarean scars and ectopic pregnancies. And we also have co-moderating with me my colleague, Professor Christoph Lees, who obviously is more attuned to, shall we say, obstetrics and runs the AIP service at Imperial. So I'll just hand over to Christoph to say a few words as well, and then we're going to start things off with our first speaker. Christoph, you may have a few words to say as well.
Yeah, thank you very much, Tom. You're absolutely right. It's really wonderful to bring together early pregnancy, gynecology, imaging, and obstetrics, because this is all a continuum, and it's really important to view it in that context. And often there's this artificial divide between abnormal implantation in the first trimester and then abnormal implantation in the second and third trimesters. So through this program, you'll see we're going from early pregnancy, imaging, surgical management, and I hope that'll provoke a very interesting discussion at the end. So I'll hand over to Tom, who will moderate, I think, the first part of the webinar, and then we'll move on to the later pregnancy part. So I'm looking forward very much to hearing what our esteemed speakers are going to say.
Thanks, Christoph. You're absolutely right. Everything starts in early pregnancy. Obviously, it's where all the action is these days. In fact, I think as we look in the future, we're going to find more and more webinars like this where people will be looking in the first trimester, whether it be IUGR, whether it be, you know, preeclampsia as well. I think this idea that early pregnancy is a different continent almost is going to change over time. So we're going to start looking at caesarean scar pregnancies, diagnosis, management, and also something about management, and I guess to some extent about sort of almost the ethics of what we do with scar pregnancies, because you know, the scar pregnancy that we see in an early pregnancy unit very much becomes the problem on the labour ward later on in the majority of cases. And obviously there is this kind of vexed question of you know, what do you do with them? Do they all need to be in effect terminated, or can we counsel some women who will make the choice to carry on with their pregnancy. And of course, we're going to hear later on about what can happen in those circumstances. But at the end of the day, it is about giving women information and potentially giving them choices. But the first thing is we have to diagnose them, and it's a critical issue. And we've seen issues around miscarriage, about misdiagnosis of miscarriage, and ending up in the termination of wanted pregnancies. And we hopefully have, to some extent, dealt with that problem. But one of the concerns I have is that people do diagnose scar pregnancies, and certainly we see quite a few patients labelled as scar pregnancies where it's quite clear that the pregnancy is actually not in the scar, or it's very close to the scar, but actually is not going to become a major issue, or perhaps might become a pathologically adherent placenta, but nothing that can't necessarily be managed. So I do think we have to be very careful, and our first speaker will address that, the diagnosis and also the management, and I think principally the surgical management of scar pregnancy. So I'm going to hand over to my colleague, Professor George Condis from the University of Sydney. George, I look forward to hearing what you have to say. Thanks.
Good evening, ladies and gentlemen. My name is George Condis. It's currently 3 a.m. Sydney time, Friday morning, or Thursday evening, your time in London. It's a great pleasure to be here this evening speaking on this webinar through Imperial College's connections, and obviously it's a great privilege to be here tonight, being asked by Professors Tom Bourne and also Christoph Leens. So this evening I'll be talking to you about caesarean scar pregnancies, diagnosis and management. We do know that section scar pregnancies occur in 1 in 1,800 to every 2,000 pregnancies, and also the rate amongst those women that have had a caesarean section is around 0.15%. If we look at the rate amongst those women that had caesarean sections who've gone to develop an ectopic pregnancy, the rate is 6.1% of all ectopic pregnancies in women that have one caesarean section. If we look at the collaborative UK national cohort study that was led by Davor Jurkovic, in which they accessed data over a 14-month period from 86 early pregnancy units through the early pregnancy network throughout the United Kingdom. They collected data on 102 consecutive cases, which estimated their incidence to be 1.5 per 10,000 maternities. They had complete data on 92 women, and when they looked at the outcome for these women, 23% were managed expectantly, 16% were managed medically, and the overwhelming number of women, 61%, were managed surgically, with the highest rates of success seen amongst those surgically, followed medically, and subsequently the smallest rate of success seen within the expected management group. And from that UK cohort study, they concluded that surgical management appears to be the most successful, with the lowest rates of complication, the shortest post-treatment follow-up. When it comes to managing these women, the most important aspect of management is having the certainty of diagnosis, and this is where ultrasound comes into play. And so there are specific criteria that we use for the diagnosis of section scar pregnancies, and it's really important to assess the uterus both in a mid-sagittal plane and transverse plane, but also at the same time to have an understanding of where we believe the gestational sac is implanted. And in those women that had a section scar pregnancy, it's important to determine that the upper uterine cavity is empty. So too is the cervical or endocervical canal. The gestational sac itself has implanted within the niche or the scar defect within the anterior myometrium above the level of the isthmus. When we use colored Doppler examination, we often see that this is somewhat vascularized or richly vascularized. And importantly, when we place pressure on the at the level of the anterior cervix and press against the uterine lower segment and also the gestational sac itself, the two move together, so there's a negative sliding sign. So it's really important to make a clear distinction between a section scar pregnancy as opposed to a cervical pregnancy, as opposed to a miscarriage that's happening in evolution, that's passing past the old section scar and passing beyond the isthmus and then obviously through the endocervical canal itself. And it's also important to make a distinction between a true section scar pregnancy and a low intrauterine pregnancy that's implanted low within the uterine cavity itself. So there are specific criteria that we use, and the certainty of diagnosis is important when it comes to determining subsequent management strategies. Here are some other images where we can see quite clearly that we've got an anterior a gestational sac that is implanted within the myometrium anteriorly at the level of the previous cesarean section scar, above the level of the isthmus, and again in this mid-sagittal plane. Again, here's a nice view of the endocervical cavity. There's a gestational sac with yolk sac within the anterior myometrium, and the upper endometrial cavity is normal. There's varying colour Doppler scores, but often these women do tend to have a relatively high colour score, 3 or 4, so either rather strong or very strong vascularity. Here are some videos from my unit here in Sydney, and there's no doubt that the earlier the diagnosis of this condition, the relative ease with which it is to manage these patients. So you're dealing with a much smaller gestational sac, you've got a smaller trophoblastic surface area, a lower trophoblastic load. These women tend to, at early gestations, have a lower HCG level, and so they're more likely to respond to either medical management or surgical intervention. In contrast, if these women are diagnosed later in the first trimester, so beyond 8-9 weeks gestation, with a larger gestational sac, a larger trophoblastic load, a larger trophoblastic surface area, then they're more likely with surgical intervention to have a much higher rate of bleeding at the time of surgery. And it's another example here with a video on the left with, without colour, showing a gestational sac that's implanted within the lower anterior myometrial aspect of the uterus at the level of the previous cesarean section scar, with a yolk sac present with minimal vascularity, so no obvious or no clear CRL developed at this stage yet in this early section scar pregnancy. So having made the diagnosis, and I think it's always important if you've got any doubts about the diagnosis for these women, there's no problems in getting them back for a repeat scan within 7 days. And it's also, I think, really important if you've got any doubts about the diagnosis in these women, it's really important then to scan them again with a senior colleague so that you together can be very clear about the diagnosis in relation to the location of the pregnancy. So this is an extrauterine pregnancy. When it comes to management strategies, although there is limited information in relation to the natural history of women with cesarean scar pregnancies, at this point in time, the body of evidence based upon cohort studies, prospective studies, and luminary units, individual luminary units, particularly based in London and New York, feel that delay in diagnosis in relation to these women with section scar pregnancies could in fact lead to uterine rupture, the potential for preterm delivery, major hemorrhage due to different forms of accreta and percreta, and even a risk of cesarean hysterectomy with serious maternal morbidity. However, I would say that again, when most of the data in the literature is contributed to by a few luminary units around the world, then obviously the view of those units is going to somewhat skew the literature in relation to the way in which we would view this as an entity. And as I said here, there is no consensus in the way in which should be managing these women. And if you do look through the literature, there are different surgical approaches. So it's possible to do transabdominal ultrasound guided curettage, transrectal guided ultrasound curettage, to use a Foley's balloon catheter if there's excessive bleeding at the time of the surgical evacuation. Yurkovich's group advocates the use of an elective Shirokova suture such that if there's bleeding, then to tie that off at the level of the isthmus. There's described laparoscopic techniques, hysteroscopic approaches, the use of medical management in the form of methotrexate alone. Some units advocate the use of methotrexate followed by potential curettage after the Doppler signal has reduced in intensity. There's even the use of the double balloon tampon, and some women whose levels are falling at 48 hours can have their section scar pregnancies managed expectantly. If we look at the large systematic review of treatment studies that was performed by Peterson et al., where they reviewed 52 studies, of which 4 were randomized controlled trials, we could see that based upon their analysis, that intervention rather than the medical approach seems to be supported. However, larger, well-designed multi-center studies are required in their view for us to have a fair understanding of not just the natural history, but also the optimal approach to these women. One of the potential downsides to medical management, and this is in a case that we managed at Nepean Hospital, and there's multiple cases that are described in a similar fashion in the literature, is that you can end up in a situation where there's resolution of the HCG or the pregnancy state, but there's still the presence of a gestational sac or tissue within the myometrial, lower anterior myometrial defect. And so these women post methotrexate successful management, because they've got tissue and or gestational sac present, even though they've got a negative pregnancy test, they can then end up having ongoing bleeding issues, resulting in the need for subsequent surgical intervention in the form of curettage. So on the basis of that, there's been a move away from medical management more into surgical intervention, such as ultrasound curettage. Jukovich's group in 2016 published the largest series to date on surgical treatment for section scar pregnancies. And in this cohort of 232 women were managed surgically, only one of these women required a life-saving hysterectomy, and the rate of transfusion was 4.7%. So it was felt in their hands that ultrasound-guided suction curettage was an effective and safe method to manage women whose pregnancies have implanted in the lower uterine section, segment at the level of the previous cesarean section scar. And that remains the largest series to date. Across the Atlantic, Timur Trich's group in New York have published many studies, including this case series on 60 cases, where a proportion of these women were managed expectantly with fairly poor outcomes. So based upon work from his group, he feels that expectant management is not necessarily the best way forward. They had a hysterectomy rate of 11 cases having a hysterectomy at the cohort of 60. And he feels that it's much better to intervene in a proactive way, surgically or otherwise. One of the other, and I think, innovative ways that his team has managed these women is to use a double balloon catheter and to almost create a tamponade effect with the section scar pregnancy itself. And so I'll come to the video on the next page, and we see here that as I roll that video, it's a double balloon catheter, and there's a distal balloon and a proximal balloon. And patients that are clinically stable, whose levels are rising, can be offered balloon tamponade for their section scar pregnancies. And early in their experience, in those patients that had section scar pregnancies, you can see here that the intrauterine balloon catheter is inserted into the uterus. The upper balloon goes past the niche or the anterior myometrial defect into the endometrial cavity itself, and that's insufflated with saline. Then the second balloon catheter is insufflated with saline, and we can see here that as that's insufflated, there's the gestational sac there inferior to the balloon catheter that's insufflated in the upper endometrial cavity. And as that second balloon catheter is insufflated, we can see here that the gestational sac is mechanically squeezed quite firmly between the two catheters. And so this results in a mechanical tamponade of the gestational sac itself, which in turn results in a decrease in the HCG levels. And so this is a safe way to manage these women non-surgically in an outpatient basis with good results. In our unit here at Nepean, we've been a strong advocate of transrectal ultrasound-guided curettage, and we published on this in the White Journal now more than 10 years ago. And I think the type of ultrasound that you use is not necessarily that critical, whether it's transrectal or transabdominal. I think that the reason that I would advocate the use of ultrasound if you are going to be performing a surgical evacuation of the lower anterior uterine segment where the gestational sac is implanted, is that I think it can reduce the, under direct visualization, reduce the risk of perforation and obviously damage to surrounding structures. And we know that the bladder often in these pregnancies and the gestational sac is very close to the serosal edge, so it could be quite easy to have an anterior perforation through into the bladder itself. So obviously we can mitigate that risk by performing the ultrasound guidance under direct vision. I think one of the other benefits of performing ultrasound guided curette in our hands is transrectal ultrasound guidance, is that it minimises the risk of retained products. And so you can very carefully and very systematically empty the lower anterior myometrial defect or niche of the pregnancy sac and its contents quite cleanly and quite clearly. And so that negates the need for a second evacuation or second surgical curettage. And so under those circumstances, then you would not miss that gestational sac, which I think would be possible to do if it was a blind curettage. And so we can see here in this video, this was published in the White Journal 2010, we can see here that the transrectal probe is sitting, obviously, the transvaginal probe sitting in the rectum. So the image is almost inverse and upside down. But we can also see here that the bladder is to the right of the screen. This is the anterior myometrial defect. In the first video, we can see that the curettage itself almost shoehorns the gestational sac out of that anterior myometrial defect itself. And in the second video, we can see that the gestational sac has been evacuated quite carefully and quite clearly. And now we're just emptying out any residual contents within the myometrial defect itself, being careful not to traverse the serosa of the anterior myometrium, thus avoiding or averting a perforation of the uterus and entering the bladder. And then in the final video, we can see quite clearly that now we've just got a bit of residual bleeding back into the uterine cavity itself. So a safe technique, a really clear views, and on occasions, if we have that bleeding, if the patient's consented, the anaesthetic team is obviously prepared for potential for massive bleeding protocol, and we also involve senior clinicians with the use of balloon tamponade with a Foley's balloon in the event that we've got significant bleeding at the time of curettage. And once that Foley's balloon goes in under direct vision, it then creates tamponade, prevents any bleeding, and it can stay in for 12 to 24 hours and then be removed on the ward quite safely. So as I said, transrectal ultrasound is our method of choice. In Yurkovich's hands, it's transabdominal ultrasound guided curettage. I think either way, I think you can get a very good result indeed. To conclude, I think that the certainty of the diagnosis is, the certainty of the ultrasound diagnosis is really critical before we decide to implement any sort of management strategy. And to date, there is no consensus on the optimal management approach in these women that are classified as having a septic scar pregnancy. Bassey Tilak has linked up with Elaine Timor Trich's group, and they are now developing an international septic scar pregnancy registry in an attempt to try and improve our understanding of the natural history of this condition, and in turn formulate strategically but evidence-based approaches to the way in which we should manage such women. And remembering again that at the moment there seems to be a preference or a bias towards managing these women surgically. However, having said that, I think the management of any woman should be individualised, and the patient themselves should be counselled such that they can make an informed choice between either proceeding with first trimester surgical intervention or deciding not to intervene surgically in the first trimester and continue the pregnancy, but then in doing so understand the potential risks in relation to the pregnancy itself, with the risk of preterm delivery, the risk of conditions such as percreta or accreta, which can result in significant blood loss at the time of delivery, the potential risk for emergency hysterectomy, which in turn could result in obviously a loss of future fertility. So I thank you for your time, and I hope you've enjoyed this overview.
George, that's fantastic. Thanks very much. It's quite a run through of the various issues that relate to scar pregnancy. I think because of time, George is not able to make a Q&A to discuss things. I just wanted to raise a point to those of you who are listening. I think there's a chat function which you can see, and also live Q&A from the right-hand side, certainly on my screen. If you have any questions, if you could type them into the Q&A function, question and answer function. Both myself and Professor Lees will do our best to put your questions to the panel. I'm going to turn to our next speaker because George isn't here to answer questions. And just kind of, if it's okay, I'm going to introduce our next speaker, but I'm going to then ask her not to speak, which is a kind of weird thing to do, but there we are. So if they can just hold on and not play the video yet, Samsung. So I'm very pleased to introduce Maya Al-Mamam. There's a consultant gynecologist at Imperial. She is the lead at Imperial College for adolescent gynecology, but also an expert in the care of early pregnancy patients and also rapid access for cancer. So I'm not sure there's anything you don't do, Maya, but anyway, there we go. I'm going to give you that label for the purposes of this webinar. There are a couple of things that have been asked. What's your view about using potassium injection? I mean, we've heard from George about medical management. I mean, I have to say I'm hugely biased myself to the ultrasound guided surgical approach, certainly in the first trimester. It seems to me a very straightforward procedure, and I've never really understood, you know, we've not seen many people having catastrophic bleeding with that, but what's your view?
I mean, I think as a whole, we all prefer here to do the surgical management. Expectant management is an option, and the data suggests it can be successful in a small minority of cases. But the problem with expectant management and doing nothing is that if the woman comes in the middle of the night bleeding heavily, you need to be sure that you have a system that's robust to be able to provide emergency care that could be quite complex in these potentially complex surgical procedures in an emergency. So I'm not a huge fan of the kind of expectant approach. The medical approach, where giving methotrexate or potassium chloride, again, I don't think there's a huge amount of data to say that it's successful. I think there is obviously going to be some success, but the problem that is reported, and we've seen the complications of it, is that as George alluded to, is that you end up leaving the sac. And so what happens is there is some resolution, but women have this horrible bleeding and discharge, and you end up having retained products or a gestation sac that remains embedded within the cesarean scar niche. And then your hands are tied and you end up having to do a surgical intervention. So I'm not a huge fan personally of the medical approach. And I think there's a lot of good data to show the surgical approach using ultrasound guided surgical management with the possibility of an insertion of a cerclage or a balloon if you get heavy bleeding. I think that's been shown to be relatively successful procedure. In Davol's paper in 2016, that's a huge case series of 232 women, and I think only one hysterectomy. So I think that shows that that is a kind of safe procedure.
Yeah, because I'm not convinced by the, you know, you see all these things about embolization before surgery. I think, you know, for me, under 10 weeks, you can just, it's pretty straightforward, and you can use abdominal scanning, you can use transrectal scanning. I think transrectal scanning is much underutilized actually, because obviously you can, it's easier to put instruments into the uterus and so on. Over 10 weeks, maybe more likely to have to use a suture. It's a problem when you get that group which are over 12, 13, 14 weeks, and then of course it does become much more complicated. And so to me, it's this problem of trying to get early diagnosis where potentially the diagnosis is more likely to be wrong, because it's pretty easy when you've got a big scar pregnancy at 14 weeks. It's, you know, you can't miss it, but at 6 or 7 weeks, sometimes maybe it's a problem. Okay, I just wanted to explore those things with you. What I think we'll come on to a wider discussion with you later on, because what I'd like to do is hear from you now about the possibility of managing some of these scar pregnancies expectantly. I mean, obviously, we want to keep some of them in order to give people like Andrea and Professor Lees, you know, heart attacks later on when they turn up on the labour ward. But anyway, let's hear what you have to say, Mayor. So let's hear about managing scar pregnancies expectantly and what your views are on that. I'll hand over to you.
Good morning, good afternoon, and good evening to you all. Thank you for the invitation to speak to you today about the expectant management of caesarean scar pregnancy. The incidence of cesarean scar pregnancy is difficult to accurately estimate given the diagnostic criteria changes. However, it is increasingly seen with the rise in cesarean section delivery, and this is mirrored by the rising rate of morbidly adherent placenta. In fact, early placenta accreta diagnosed in the second trimester has very similar features to cesarean scar pregnancies histopathologically. And all three conditions, cesarean scar pregnancy, early placenta accreta, and morbidly adherent placenta, share two important attributes. One is that they implant over a previous cesarean section scar, and the other is that they lead to serious obstetric complications. Professor Kondus has shown us the diagnosis of scar pregnancy and the key features demonstrated in these images. And it is clear from the existing literature and our experience that early diagnosis is key to accurate counselling and surgical management, and that diagnosis in the first trimester is possible and has been shown to be accurate on the whole. However, there are no real large multi-centre prospective diagnostic test studies to be certain of this, and this remains a real issue. Optimal treatment has not really been determined, and couples are often offered termination of pregnancy due to the high morbidity. The association, however, between scar pregnancy and abnormally invasive placenta raises questions as to whether termination is really the only therapeutic option, and what proportion of cesarean scar pregnancies would progress to a viable birth, and how we can identify cases that will have a successful pregnancy outcome. The majority of published series on scar pregnancy include really symptomatic cases or those undergoing emergency treatment. And so it makes it very difficult to estimate the actual burden of maternal morbidity associated with the condition. And so what data supports an expectant approach in this patient cohort? Well, there have been a number of published case series. This is a study based from Jackie Ross's group at King's College, and it's one of the few prospective studies. And this is based on 10 women diagnosed with a pregnancy implanted on or within the cesarean section scar in those couples who declined intervention or were committed to the pregnancy. The majority in this series presented early in the first trimester, between 4 to 9 weeks gestation, with either pelvic pain or vaginal bleeding. Diagnosis was really confirmed later in the first trimester after 8 weeks. 4 of these pregnancies went to term. I should say that all of these pregnancies had a live birth, and 6 were delivered preterm. 5 required cesarean hysterectomy. And although this is a small series, looking at the data, the first trimester ultrasound findings that seemed to be most predictive of pregnancy outcome were the presence of the majority of placental tissue and cord insertion within the scar defect, as in cases 3, 5, and 7, and bulging of the trophoblast outside the uterine contour, as in case 5 and 9. It was also clear from the study that it was best to wait later in pregnancy, after 8 weeks, to assess the degree of implantation and be confident of the diagnosis. The findings of this series suggest that in certain cases, a live birth is possible, but is this always the case? I wanted to share with you 2 case examples from our unit at Queen Charlotte's that hopefully demonstrates that things are not always as clear-cut. This first case is a 40-year-old who'd had 3 previous cesarean sections. In addition, in her last pregnancy, she was diagnosed with a cesarean scar pregnancy and offered a termination or expectant management, and had opted in that pregnancy for a termination. And she had undergone a successful surgical termination of pregnancy with insertion of cervical cerclage. She came back pregnant again and was referred from a local unit for a second opinion at about 7-8 weeks gestation. We confirmed a viable intrauterine pregnancy. However, the anterior myometrium was incredibly thin, and it was clear, although she remained asymptomatic, that this was an anterior low implantation overlying the scar, although not completely within the scar. She had very little residual myometrial tissue, and we discussed the risk of accreta with her and offered her termination at this stage. However, she was very committed to this pregnancy. She had a routine dating and anomaly scan, and an anterior low-lying placenta was noted, and she went on to have care in our fetal medicine unit. which demonstrated again an anterior major placenta previa covering the internal os. There was a clear hypoechoic placental myometrial surface and no obvious vessels crossing this region to suggest invasion into the bladder. And it was felt that this was an accreta. This patient remained an inpatient with recurrent antepartum hemorrhages in the third trimester and was delivered at 35 and 2 weeks gestation. She had a live female infant who weighed 2.2 kilos with good outgars. At cesarean section, it was found that she had a placenta accreta and she went on to have a cesarean hysterectomy with a blood loss of 5 litres. And both mum and baby did very well. This is our second most recent case. This is a 36-year-old with a very complex obstetric history. She had late pregnancy losses and preterm births suggesting cervical incompetence, and she'd had cervical cerclages in previous pregnancies. In addition, her last 2 pregnancies were cesarean sections, and the last, in 2017, she had a uterine rupture, resulting in an emergency section. Incidentally, to further complicate matters, she had immune thrombocytopenia in terms of her past history and had platelets of 41 when we saw her, and she had a very raised BMI. And she attended at 11 weeks with vaginal bleeding, and this is what we saw. The placenta was anterior, low-lying and covering the os, and there was a large defect in the lower segment over the previous cesarean section scars, and a portion of this placenta was located within that defect and covered by very thin serosa. The bladder overall appeared mobile, and there was a tiny adhesion, but there was no obvious vessels crossing it to suggest a accreta, and we felt at this stage that this was an increta. The cervix was very short in keeping with her history, and she also had a subchorionic hematoma. She was again counselled extensively and opted and remained committed to the pregnancy and declined intervention. She was admitted at 12 weeks gestation with very heavy bleeding, and she bled at over 1.5 litres, almost 2 litres, and she decided at that stage, given the risk to her life, that she agreed to a termination. She underwent a surgical termination of pregnancy. However, she bled extensively from this, and a decision was made to perform a total abdominal hysterectomy. And again, a diagnosis of an increta was made with no evidence of percreta, and she made a good post-operative recovery. Both cases had very similar diagnoses, but very different prognosis. And so is there really any more data that can help inform our counselling? Well, this is a systematic review and meta-analysis of case studies published in 2018, and it included 17 studies, 15 of which were retrospective, 2 prospective, and this included 69 pregnancies in total. They divided the outcomes into those cesarean scar pregnancies with a heartbeat and those without. Cesarean scar pregnancies with a heartbeat totaled about 52 women. And you can see that in the first and second trimester, there was still a high risk of heavy bleeding, up to 12.9%. And 20% of cases required surgical or medical intervention at that stage. 13% of women experienced an uncomplicated miscarriage, and that did not require any intervention. But 20% of cases, miscarriage was complicated and required intervention. Uterine rupture during the first or second trimester of pregnancy occurred in just under 10% of cases, and hysterectomy was required in 15.2% of women. 40 women progressed to the third trimester, and all of these women had a live birth. However, about 39% had severe bleeding, and uterine rupture occurred in about 10% of cases. Interestingly, a pathological diagnosis of abnormally invasive placenta at delivery was made in about 75%, and this is interesting because it suggests that we're not always right, and that potentially the diagnosis was not correct and the patient didn't have a morbidly adherent placenta. However, this isn't really discussed further in the paper. Overall, the hysterectomy rate was about 60%, and there were no cases of maternal death in these cohorts. In those without a heartbeat, this totaled 17 women, so much fewer, and the majority experienced an uncomplicated miscarriage in about 69% of cases, whereas the remaining 30% required some surgical or medical intervention after miscarriage. Uterine rupture during the first trimester of pregnancy occurred in about 13% of cases, and there were again no cases of hysterectomy or maternal death in this cohort. So it's interesting that outcomes appear to differ depending on the viability of the pregnancy. And those pregnancies that continue have a 70% chance of a live birth, but also a very high risk of hysterectomy of about 60%. And those that are non-viable, although 70% miscarry without complication, there's still a high percentage of 30% that require an intervention. All these studies have a number of limitations. One question is really the accuracy of diagnosis in those deemed non-viable scar pregnancies, where possibly the miscarrying pregnancy was low within the cavity, but not actually implanted within the scar. In addition, as explained earlier, the majority were retrospective. They were based on small numbers of cases, and they're not randomized. And in addition, one worries that what we're looking at is a selected population, as more severe patients who are symptomatic may have had an intervention and less likely to have been offered expectant management. And so there's this possibility of this degree of selection bias. Knowing that some of these pregnancies can survive and some end, unfortunately, with no baby and no womb, can we do better than just diagnosis? Can we risk stratify? Acton et al. Suggested that those pregnancies implanted on the scar, as shown in this figure, do much better compared to those pregnancies implanted within the scar, as shown by these images here. Interestingly, very similar data from this group published in the White Journal that suggested this relationship was key to predicting the severity and the type of abnormally invasive placenta. In addition, they looked at residual myometrial thickness, and where this was less than 2 millimeters, this seemed to be associated with more adverse outcomes. And so a sensible grading system has been proposed, and this is a really good idea as it helps standardize our diagnostic criteria, and the grading of the degree of placental invasion will then help us to better determine outcomes and prognosis for these women. We have answered a lot of these questions on this slide, but the last question remains is, can we prevent this? These are two papers, a small case series, where those with a caesarean scar niche who had gynecological symptoms had the niche hysteroscopically repaired. Their gynecological symptoms were improved, and pregnancy outcomes were obtained.
So, Maya, are you there?
And in these cases, there were no cases of morbidly adherent placenta or hysterectomy. However, these were very small studies, and they weren't really powered to evaluate obstetric outcomes. They reported the outcomes anyway. Vitala published this recent systematic review and meta-analysis, which included various case series and single-arm cohort studies looking at repair of niche and outcomes. And despite promising outcomes so far, there's no real definitive proof of the beneficial effect on reproductive outcomes of any intervention over expectant management. So we don't have the data as yet. And what we really need is larger multi-center prospective randomized studies to truly assess if repair of niches reduces the incidence of scar pregnancy or morbidly adherent placenta. Based on current evidence, this is a proposed management protocol of how to kind of approach a scar pregnancy. I think the first thing, the key thing is getting the diagnosis right. And in case of any diagnostic uncertainty, particularly in the very early stages of pregnancy, it's really important to just repeat the scan or, if required, seek a second opinion. In the case of a non-viable pregnancy, the patient could be counselled about the option of expectant management, as 70% from that data had no complications. However, this really depends on the patient's wishes, the availability of emergency care in the case of very heavy bleeding, and local resources. And therefore, a suitable and sensible and pragmatic alternative is to offer surgical management of miscarriage with insertion of a cervical cerclage. Requires adequate counselling about the risk of bleeding, and also remember there still remains a small risk of uterine rupture and hysterectomy in this cohort. And of course, it's important to offer a repeat scan and supportive care. In the case of those with a viable pregnancy, it's important to fully counsel the patient about the options and potential outcomes, including the risk of pregnancy loss in the first and second trimester, with the risk of hysterectomy at that stage. And should the pregnancy progress, of course, the risk of prematurity, significant morbidity from surgery, and hysterectomy. Important to give patients time to make their choice, and if they opt for a termination, they can be offered a surgical termination of pregnancy with insertion of cervical cerclage. In the case of expectant management, it's very possible to manage within the MDT, and you can think about using your fetal medicine team, the gynaecologist, obstetrician, neonatologist, who will work all together to care for these women throughout their pregnancy. You can also think about using these risk stratification tools to help guide you, including the residual myometrial thickness and the relationship between the scar and niche. So in conclusion, early diagnosis is key to accurate counselling and surgical management. And diagnosis in the first trimester is possible and has been shown to be accurate. However, more formal diagnostic test studies are needed to validate diagnostic protocols. Although optimal treatment has not been determined, it is reasonable to offer these couples termination of pregnancy due to the high morbidity. However, it's also reasonable, given the data showing the number of live births that are possible for these women, to counsel about expectant management, although this needs to be balanced against the risk of morbidity, including prematurity and hysterectomy. Multi-center prospective studies are needed to improve the diagnosis and risk stratification and better understand the prognosis, and that will really help guide our management and counselling of this patient cohort. Thank you so much for listening, and I look forward to your questions.
Mayor, thanks very much. That's great. Yeah, I mean, it's a difficult issue, isn't it? I'm just going to run through some of the questions that I can see coming through, because I think it's important that we deal with those. Is that okay with you?
Yeah, of course.
Wonderful. Okie dokie. So just talking generally, there's Debbie here who's asked whether there's a place in treatment for hysteroscopic resection. We're going to try and keep these fairly short. You know, yes, no, what do you think?
I mean, again, we just tend to stick to surgical management because we know that's very successful, and actually there's a lot of data out there and published literature from particularly from Davor Jerkovic group about the success of that procedure. I can see the potential benefit of hysteroscopic resection, but I guess you worried that you maybe don't because you're not able to see from the top. One of the beauties of doing the ultrasound guided surgical procedure is that you can see that from how far into the myometrium and into the scar niche you're going, and be certain that you've removed all the trophoblast. And I'm not sure hysteroscopically how you can achieve that, but I mean to me.
Doing procedures in the uterus without ultrasound makes no sense, and we have this tool that enables us to see what we're doing, and as you say, looking at you've seen all the video from George. So anyway, answer to the question, I think the consensus is, I mean, I never say never, because I think people use what they're best at using, but at the end of the day, I think my feeling is that ultrasound guided aspiration will win the day. Interesting. I mean, there's a comment here that if you repair the niche defect laparoscopically, you can have a VBAC in the next pregnancy. Now, Avidia, that's quite a strong statement, I would say. I know where you're coming from. I mean, I guess this is $1 million question as well, isn't it? I mean, you can repair these niches. But I think the jury's out. We don't have good data, do we, Mayor, really, in terms of the impact. It seems to make sense in some cases, and obviously after some of these scar pregnancies, when you look on scan, they've got a huge defect. So. What do you feel?
Well, I mean, the studies that have been done have looked really at the gynecological symptoms, and so they've repaired a niche and they've looked at women's symptoms, and that on the whole has demonstrated some improvement, for example, in irregular bleeding, intermenstrual bleeding. But obstetric outcomes, there's not been really a powered study to review that, and the case reports have found that actually they've not found any incidence of morbidly adherent placentas or hysterectomy. But I have to say that all those women in the case series that I alluded to in the presentation all had planned cesarean sections, so they didn't VBAC. So I don't think we know about the safety of that really.
Seems pretty sporting. Seems pretty sporting to go for a VBAC, but there we go.
Can I just come in there, Tom and Mayor?
Yeah, of course.
You're absolutely right. As a serving obstetrician, I have to say that I think I would fall off my chair if before going for a VBAC in someone with an laparoscopic repair of the scar. Although the scar itself may be knitted together, it would almost certainly be pretty thin and pretty deficient. Is my view. Maybe I'm too cautious, but I would go for a cesarean, and I'd go for an early-ish cesarean as well.
Yeah, which is what the case reports did. Between 35 to 38 weeks, they delivered the women. So
Okay, well, I'm going to move on. I want to try and get through, and then we're going to take a couple more issues, and I'm going to hand over to our next speakers. I know that time is short. Look, I mean, bottom line is, Mayor, I mean, it's about, we really need to establish a sort of sub-classification of these scar pregnancies and relate those to outcome. I think that's really the message, because if we're going to counsel people properly, it's obvious that these are not all the same beast, are they? We've got scar pregnancies, we've got pregnancies near the scar, over, into and through. I mean, is that a fair comment?
Yeah, and I think somebody commented about what's the difference between early accreta and scar pregnancy ectopics. This is all a spectrum of a very similar condition, and it's all differences in terminology. But what we really need to do is standardize the way we describe these and the grading system, so we're all speaking the same language, and then follow pregnancies through. So that will really help us prognosticate and understand who's at most risk and which ones are behave maybe more like ectopic pregnancies, and which ones behave more like an accreta and may end up in a live birth. And the other important thing about that is that there's some data coming out, and I didn't have time to go into it in the talk, about the kind of sensitivity, the performance of ultrasound in predicting morbidly adherent placentas. And there was a paper in the AJOG last year, but it was a retrospective review, and it showed that the ultrasound at between 11 and 13 weeks has very high specificity at diagnosis, at morbidly adherent placenta, but not really very good sensitivity. So the problem is we don't want to get this wrong either and potentially terminate very wanted pregnancies. So we need to work more about the diagnosis and terminology, and really have more prospective studies looking at the outcomes of these pregnancies.
Mayor, fabulous. I think you summarised it very well. So thanks very much for that. We're going to move on. I mean, I think the point you made at the end, in a sense, with cesarean scar pregnancies, we're where we were with things like IOTA, and I don't know so much about truffle, but it's a situation where we need to all agree on defining the terms of what we're looking at, and then establishing big studies, which are inevitably going to be multi-centre because it's a relatively rare condition. I can't talk about it much because it's not published, but Judith Hearn has been driving a Delphi study producing a sort of nomenclature reporting system for scar pregnancies, and that's just about, I think, in the current round of being assessed in one of the journals, and that comes up with, I think, a good description of these, and hopefully that can be used so people can use those in studies, and then we can relate. Everyone will talk about the same thing, and we can relate those to outcomes. So I think that's probably the way forward. We may come back to you, Mayor, so hang in there. We're going to move on. I'm really, really pleased that we've got Rosie with us, who's our next speaker. Rosie Ariananda I think, leads the Placenta accreta team in Surabaya in Indonesia, and I first heard Rosie speak at a big meeting in Singapore. And so I was really pleased that he is able to be with us today and accepted our invitation to speak. He's going to speak about the referral system for AIP in Indonesia and his part of the world, and he's also got a wealth of experience on the surgical approaches to this problem, and he's going to come back later as well and talk with Joseph and Christoph Lees, who are going to be discussing that aspect of the management. So Rosie, I'm going to hand over to you. Rosie also, I saw when on the screen, he's got several guitars in the background in the room he's speaking from, so we're hoping to get him to play later on. So we may get that as well, Rosie. So the pressure's definitely on you for your later performance. Thanks very much, Rosie.
My name is Rosie Aditya Ariananda. I'm from Surabaya, Indonesia. I would like to present our experience for the placenta acta spectrum and about our referral system. So first, about Indonesia, we are number 4 highest population in the world. So we have a big population, and this is the Indonesia. We close to Malaysia, Singapore, and Australia, and we have about more than 200 million people, and majority, more than 50% live in Java, and we have high number of maternal mortality rate, about 305 per 100,000 live birth. So this is Surabaya. We are in the East Java province, and a lot of study who mentioned about the high rate of cesarean section, which is usually they correlate with the incidence of placenta acta spectrum, and some of them said about the nutrition, obesity, and the others. And we have the big problem is this is our health system in Indonesia. We have a lot of problem in the obstetric health system in Indonesia, but I'm focusing in the four thing. Referral must be tiered, doctor salary and low, and we work in the 3 workplace, and we really bad in the data collection. So for the health system in Indonesia, there are primary healthcare and there are secondary healthcare, which is divided into the small hospital until the big hospital, and the tertiary hospital is type A hospital. Like in our hospital, usually we manage the complicated cases. About the referral system in obstetric cases, about the antenatal care, usually they have antenatal care in the primary healthcare majority, and they cannot refer the patient directly to type B or type A hospital, except for the emergency situation. This is why it's difficult to detect cesarean scar pregnancy, because they usually refer to obstetrician in the 2nd or 3rd trimester, and a lot of cases was undiagnosed of placenta acreta, and they got the management in without any experience and low facility. So about the issue of the doctor salary, because we work in the 3 hospital and we have to multitasking doctor, and a lot of us think that vaginal delivery is wasting time, and the cesarean section give more proper salary from the government insurance, and we don't have any fixed salaries. That's why we prefer to do cesarean section. Even for the government institution, there are 2 focusing to write the statistic, and the first one is National Baseline Health Research, say that about our cesarean section rate is 16%, and the government insurance said about the cesarean section rate almost 40%. So we don't know exactly our cesarean section rate, because some hospital from the government insurance said about some hospital have number of cesarean section rate is almost reach 100%. So we don't know how about the real number. But the placenta acreta spectrum itself, the Professor Jody said about the iatrogenic 20th century disorder, because the major risk factor is cesarean scar. This is our experience. We have about 450 cases. We already managed all cases of placenta acreta spectrum. We already exclude the Gleason uterus and placenta previa. So we really have a lot of cases of placenta acreta spectrum. And we have the important time, which is in the 2015, there are 4 maternal deaths in Surabaya due to postpartum hemorrhage, and 3 of them because of placenta acreta spectrum, and 2 of them is the doctor. So we think that there is something wrong. So in the February in 2016, we make the symposium about the placenta acreta spectrum. We're focusing about the awareness and how to diagnose it. And then at the time, we routinely do the hysterectomy in all placenta cases with the internal iliac artery ligation. And October 2016, we learned from the expert, this is a Prof. Palacios Characuemada from Argentina, and this is Professor C from Taiwan. We work, and after that, we try to conserve the uterus and then do the reconstructive surgery with internal iliac artery ligation for the upper bladder invasion. For the lower bladder invasion, we still do the hysterectomy with internal iliac artery ligation. About maternal death of placenta accreta in our hospital, we because of the increasing of the refer patient, increasing the case of undiagnosed patient of placenta accreta spectrum, we try to analyze because a lot of maternal death due to lack of experience of the OBGYN, and we have a lot of cases like in the video you can see there is a massive bleeding during the surgery, and they refer to us, and even for the massive bleeding during because of the bladder invasion. Yeah, you can see. And then after that, in November 2017, we make a second symposium of about the placenta accreta. We're focusing in diagnosis, surgical management, and centralization of placenta accreta spectrum management. And this is we have a big good collaboration with Prof. Jose Palacios Characuemada. And then we changed our procedure for the lower bladder invasion. We did the hysterectomy with a temporary aortic clamp, and for the upper bladder invasion, we changed our procedure from the internal iliac artery ligation to uterine vesical and vaginal artery control. This is the we divide the S1 and S2. It is from the Palacios Characuemada, and we divide into the upper bladder and lower bladders. For the upper bladder, we usually succeed to conserve the uterus, and then we try to compare about the cesarean hysterectomy with internal iliac artery ligation with the concept of the uterus, which is the uterine conservative surgery. We can reduce the blood loss if we combine the cesarean hysterectomy, and we combine the internal iliac artery ligation with the triple vessel ligation, which is it will reduce the blood loss if we only depend on the internal iliac artery ligation. Now we never do the internal iliac artery ligation because this video. So we have two cases with the rupture of the vessel. So we never do this again. So we prefer to bladder flap, bladder dissection using the Pelosi maneuver. We control vesical artery, vaginal artery, and goes the uterus. And this is the Nausicaa suture from the Profi. For the lower bladder invasion, we usually do the aortic clamp. And if we're comparing about the internal iliac artery ligation, the aortic clamp, of course, they will reduce the blood loss if we compare with the internal iliac artery ligation. And we have a special technique for the bladder invasion. We call the lymphatic hysterectomy, but I cannot explain now because the time is very limited. So the mean blood loss is about 2 liters, and the mean abdominal aortic temporary clamp time is about 90 minutes. And we have a lot of experience with advanced placental invasion, like a bladder invasion, and then posterior invasion. This is the sigmoid invasion, and then this is the ureter invasion in the lower parametrial invasion. And in the October 2018, we have an invitation from the International Society of Placenta Accreta Spectrum in Rotterdam at the time, and we try to compare and sharing experience, and we have a very big number of placenta accreta spectrum during 3 years at the time. And we talk about strategies to reduce maternal mortality and reduce the placenta accreta in Indonesia. And then we tried to make a national cooperation on the February 2019. We make the national task force for the placenta accreta in Indonesia, and we collect the data. Is more than 30 hospital, is about 400 cases, and majority the referral patient is in the 35 weeks, so it's quite a bit late. So we have a short-term program during 1 year. We arranged the national referral system and the coalition of 17 national placenta accreta spectrum center and improve the skill of all the placenta accreta center. And in November 2019, we make our third symposium, international symposium now, and we make a collaboration with Prof. Jose and from International Society of Placenta Accreta Spectrum. We teach them about the theory and live surgery, even for the fresh corpses hands-on and the mannequin hands-on, and we try to make the simulation about the placenta accreta spectrum. So, and then we make a national recommendation about the referral system. In the first trimester, all the gestational sec in the lower uterine segment, they have to refer. And for the second and the third trimester, if there is a placenta previa, they have to refer to Center of Placenta Accreta. The problem is in this 2020, because we know COVID-19 hit us badly in every country. Even our country now, we face the second wave for the Delta variant. The problem is if we face the placenta accreta spectrum with the COVID infection, it will give some problems, new problem actually. I worked with my friends from Colombia, Dr. Alvaro, and we compare our cases, and we can see that the surgical time is longer and the complication is higher in the COVID-19 infection with the placenta accreta spectrum than without any infection of COVID-19. This is usually because the preparation and during the surgery, we sometimes the Google will give you blurry vision, so it's very difficult to detect the vascular of the placenta accreta spectrum, and even 3 from the 4 operator get the COVID infection because the long duration of surgical time. So for the resume, every country have different problem in the placenta accreta spectrum referral system, and the centralization of management placenta accreta spectrums is important to reducing the maternal mortality and morbidity. And then we can analyze the problem in every country, and the national task force have important role to improve the knowledge and the referral system policy. And the COVID infection in placenta accreta spectrum will give you a new problem, especially for the country who have high incident for the COVID and the incident of placenta accreta spectrum. Thank you. This is our team of placenta accreta.
Rosie, thank you very much indeed. I can't see if you're online actually. Are you there?
Yes, I'm here.
Sure.
Okay.
Are you there? Yeah, okay. I know that Professor Lees and probably Joseph may want to have a few questions and discussion. I'm just listening to your talk. It obviously comes down to recognizing you have a problem. And I think different countries at different stages of getting organized and centralizing their central accreta services and so forth, and some will be more mature. I imagine in Indonesia that must be really quite an undertaking of such a huge country of so many islands. I imagine that must be extremely difficult. Quite a challenge, I would imagine, no?
I'm sorry?
Oh, is Rosie not here? Rosie, you're there?
Yeah, I'm here. Yeah, I'm here.
Yeah, I mean, that must have been quite a challenge, both practically and politically, to pull together a specialist service in Indonesia. I mean, it's a huge place.
Yes, of course, because we are archipelago islands. We have a lot of islands, so the strategy for the referral patient is it should be include all of the tertiary center, because it will difficult if I am work alone. So I have
you should buy your own jet aeroplane and fly around, you know, with your team. I think the key. I want to hear what Christoph and Joseph have to say, because I mean, one thing you obviously raised about your surgical management was you're not doing, or I think you said that you stopped doing internal iliac ligation. Christoph, what's the situation with you? And I mean, they're using an aortic clamp. I mean, I guess you're going to talk about that later, Christoph. Do you want to comment on that and what your practice is? Is there anything different? Have you followed the same path?
Yeah. Well, I think Joseph is certainly going to cover that. We do internal iliac ligation, but what I'd say is there are lots of different types of internal iliac ligation, from radiologists sticking balloons in the artery to actually ligating with suture material, to ligating with other methodologies, and to ligating bigger vessels, not ligating, but clamping bigger vessels such as the aorta. So I think that we are going to have a discussion about that after Joseph's lecture and my lecture. I'm hoping very much that Rosie can stay for that. I know it's ridiculous.
I'm loving this. I feel there's going to be a big fight going on between Rosie and you two, which I'm really looking forward to. So I'm going to direct this. There is a question here, Dr. Arianda, very, very formal. Is the aortic clamp technique also effective for posterior invasion type, or should we? It's interesting. Or should we do ligation in other vessels such as the internal iliac artery? I'm not sure if does that make sense? Not sure.
I know about the question, because if we found the posterior invasion, the important is the vessel is not from the uterine artery, so the internal iliac artery ligation actually not necessary to do that, because actually in the Monday I did the surgery with the posterior invasion, and we can see the vessel is from the branch of rectal artery. You know what I mean? So it's different. So if we try to do the aortic clamp, we should do the aortic clamp below of infrarenal artery. It's the safest if we compare with the internal iliac artery.
Okay, so I clearly I need to be careful if I have dinner with you that I don't end up with an aortic clamp on. It's obviously the answer to everything. So I can see this is how this conversation is going to go. Okay, so but actually it seems logical to me. I mean, Andrea, do you want to comment on this?
Yes, I'd love to. Thank you. Well, I mean, you will see also from my lecture that unfortunately there is no guideline on as to how to diagnose abnormal invasive placenta with ultrasound, but in such context, of course, the creation of referral units like they've done in Indonesia at Rosie's unit, such as at Imperial, it's of paramount importance, because if you create a referral unit, it means that you have someone capable to do ultrasound diagnosis. You may have someone capable to interpret MRI findings if you feel it is necessary to perform an MRI scan as a second level test. And in third instance, it means that you can have someone capable to operate whatever happens with whatever the technique is required for uterine artery ligation. So it's or iliac artery ligation. So I think that's the first step which should be done everywhere. That's my feeling. I hope you agree.
You're absolutely right on that, Andrea, and I think that was going to lead us neatly into your lecture. And as I said earlier, we're going to have a discussion, a very interesting discussion, I think, about surgical techniques with Joseph in one corner, Rosie in the other corner. I'll try and moderate with Tom, and we'll see where we get to. But no, seriously, this is. These are crucially important questions, and everyone does things slightly differently. Rosie, I have to say, I am extremely impressed that you've set up the sort of infrastructure for your Indonesian region that you have. So, organization, starting to look at your data, auditing it. Remarkably few centers and remarkably few countries do that. So well done on that. I think we're going to. I don't think, Tom, you don't have anything else to say before we move on to...
I've always got something else to say, Christoph, but I'll restrain myself. No, I want to say that I think Rosie's done a great job as well. And I think putting temporary clamps on vessels is an underestimated and undervalued thing. I mean, many years ago, doing laparoscopic myomectomies, we used to stick little bulldog clamps on and on the uterine arteries and stuff like that. So I'm glad it's coming back into fashion, Rosie. I'm all for it, mate. I'll hand over to Christoph now. I mean, I'm moving into a gestational age, which is beyond my area of competence now. So I think I better hand back to Christoph, and he'll be taking care of things from now on. Over to you, Christoph.
Well, for the next few minutes, thank you very much, Tom. Had a very interesting continuum now, and now we've reached the 20-week scan, the 24-week scans, and the sort of obstetrics fetal medicine scans that you're all quite familiar with. Andrea Dal Asta is a fellow at Imperial. He's also a consultant and professor in Parma in Italy, and Andrea and I have been working together now for quite a number of years, and we've been developing different techniques of imaging placenta accreta, really, because most of the existing 2D techniques are just not terribly good. You know, they tell you that there's a concern, but they don't tell you exactly what that concern is. And I have to say that, without stealing too much thunder from Andrea, MRI is not necessarily that brilliant either. In fact, the more we do ultrasound of abnormally invasive placenta, the less we do MRI of it. So I'm hoping that we can generate a bit of controversy as well in discussing that. Without further ado, I'm going to hand over to Andrea, who is going to talk about imaging the abnormally invasive placenta. On you go, Andrea. We can't hear Andrea.
So, Christoph, if they're going to...
And in this lecture, I will be covering the ultrasound signs of abnormally invasive placenta in the 2nd and 3rd trimesters. And why is the ultrasound imaging of the abnormally invasive placenta important? This is important because ultrasound allows the prenatal detection and risk stratification of the abnormally invasive placenta, and by doing so allows for mobilization of a multidisciplinary care team and surgical planning, which has been demonstrated to reduce maternal morbidity. And looking at the international recommendations, when are we meant to screen for abnormally invasive placenta? This is taken from the FIGO guidelines, which were published in 2018, and you can see that abnormally invasive placenta is recommended to be investigated in all women at risk based on a placenta previa, either major or minor, and a history of a previous cesarean section. Before we get started with the description of the ultrasound features of abnormally invasive placenta in the 2nd and 3rd trimesters, let's have a look at which are the limitations of ultrasound imaging so far reported. Looking at the literature, you can see that lots of data have been so far published. However, looking at the results, huge inconsistencies across studies can be depicted. This can be accounted by the fact that studies were very often retrospective in design, that ultrasound markers were not standardized, by the fact that different approaches were adopted for the imaging of the abnormally invasive placenta, and finally, by the fact that the a priori risk of abnormally invasive placenta impacts on the clinical significance of the ultrasound markers of abnormally invasive placenta. So standardization of the ultrasound markers is important, the approach is important. However, the reality is that so far no recommendation has been published as to how to systematically investigate the abnormally invasive placenta. On this basis, ultrasound practitioners need to be aware that technical issues may occur when evaluating and comparing the assessment of the abnormally invasive placenta across different centers. These issues may be represented by the selection of the transducer, which is most commonly transabdominal. However, transvaginal ultrasound may be better for the assessment of the cervix, of the lower uterine wall, and of the bladder interface. Ideally, bladder filling should contain at least 200 to 300 mL. Ideally, the pressure should be gentle in order to avoid artifacts which may mimic an interruption of the retroplacental clear space. Additional technologies may be used, such as Doppler, either color or power Doppler, and also three-dimensional ultrasound techniques, with or without rendering and with or without Doppler. Last but not least, MRI may be considered as a supplementary test in some centers in order to investigate or as a second level test for the assessment of the abnormal invasive placenta. Time is rushing, so let's get started in describing the ultrasound signs of abnormal invasive placenta. As you can see from this slide, with 2-degree scale ultrasound, you can demonstrate the presence of intraplacental lacunae, which actually represent a very common finding for fetal medicine specialists or doctors performing ultrasound during pregnancy. However, with respect to the clinical significance of intraplacental lacunae in the context of suspected abnormal invasive placenta or placenta cretae spectrum, a very recent report by the Society for Maternal Fetal Medicine stated that placental lacunae are significant only when multiple, which means 3 or more, when are large, when their borders are irregular, and when some sort of flow can be demonstrated either with color or power Doppler. Another commonly described ultrasound sign of abnormal invasive placenta is represented by the loss of the hypoechoic or clear retroplacental space, which can be demonstrated using 2-dimensional grayscale ultrasound. As you can see from this slide, you can see here the cervix. This is the placenta containing some lacunae, and this is the hypoechoic space separating the uterus with the placenta, and which is being highlighted here again. This is, of course, a normal case. In this case, you can see nicely a case where there was definitely abnormal invasive placenta, cervix, placenta, intraplacental lacunae, and you can see that at this level there is no clear separation between the placental tissue and the uterine tissue. The uterus to bladder interface can be evaluated either with 2-dimensional grayscale ultrasound or with 2-dimensional ultrasound with the adjunct of color or power Doppler. As you can see from this slide, on the left-hand side, you can nicely see a 2-dimensional grayscale ultrasound showing an irregular uterus to bladder interface, while on the right-hand side, you can see Doppler demonstrating an irregular vascular pattern, further confirming the abnormal appearance of the uterus to bladder interface, which is highly suggestive of an abnormally invasive placenta. In this clip, you can see again another demonstration of an abnormal appearance of the uterus to bladder interface. In this case, there is no clear interruption, which was seen on 2-dimensional grayscale ultrasound in the previous slide. However, you can see a very irregular shape of the interface, which is again suggestive of an abnormal invasion of the placenta. Color Doppler abnormalities can, of course, be demonstrated using 2-dimensional ultrasound with the adjunct of either color or power Doppler techniques. In this slide, you can see a case of postnatally confirmed abnormally invasive placenta. On the left-hand side, the 2D grayscale imaging demonstrates lacunae. This is a large lacuna with irregular border. Here you can see the loss of the clear retroplacental space, while on the right-hand side, with the adjunct of Doppler, you can see a highly irregular vascular pattern of this case, which eventually ended up in a confirmation of an abnormally invasive placenta. So we have described the most commonly used ultrasound markers for the assessment of women at risk for abnormally invasive placenta. We said that most of them can be evaluated using 2-dimensional grayscale ultrasound, while some of them need the adjunct of color power Doppler technique in order to be evaluated. However, when talking about the potential issues arising when investigating women at risk for abnormal invasive placenta, and particularly when comparing the ultrasound findings across different centers, we also mentioned the opportunity to use additional techniques other than two-dimensional ultrasound for the assessment of the women at risk for abnormal invasive placenta. In such context, in 2017, we presented at the ESOG World Congress the tramline sign for the assessment of the uterine to bladder mucosa interface in women at risk for abnormal invasive placenta based on an anterior placenta previa. How can the tramline sign be evaluated? Well, actually, it is quite simple. You just need to start with a mid-sagittal view of the uterine to bladder mucosa interface, which can be seen here on the top left. This view can be either with two-dimensional grayscale ultrasound alone or with the adjunct of color or power Doppler. At this point, when you have obtained a proper view with proper bladder filling, you just need to press a dedicated button, which allows you to obtain a three-dimensional ultrasound volume, which needs to encompass the whole uterine to bladder mucosa interface. At the end of the acquisition, you can see here the multiplanar view of the three planes, and while on the right-hand side, on the bottom, you can see the rendered view, which needs to be processed using crystal view and realistic view technologies. During the post-processing, following the selection of the crystal view and the realistic view modalities, you need to work on the region of interest, which needs to become as thin as possible, and then you need to orientate the volume on the sagittal plane so that you can investigate the uterine to bladder mucosa interface on the sagittal plane. At this point, you can see under normal circumstances, you can see a tramline-like appearance of the uterine to bladder mucosa interface, which can be seen here nicely. You can see here the two lines here, and then on the mid-sagittal plane, you can move from the left to the right, and then back from the right to the left here, and investigate the whole uterine the mucosa here. This is a normal case. You can see that there is no interruption of the two lines, and in this case, we conclude that there is an appearance the low risk of a invasive placenta. And here again, moving again, you can see here, again here, and again here. This is the first paper which we published on the tramline sign, in which we, of course, describe the sign, describe how to acquire it, and most importantly, correlate the appearance of the tramline sign with the intraoperative or the pathology report. As you can see here, we have three case scenarios, one with a normal tramline sign here. You can see the two lines with no interruption. At the center, you can see a case where we have an interruption of one of the two lines, and at the bottom, you can see a case where we have an abnormal finding in terms of complete absence of either of the two lines. As you can see, from the outcome, you can see that the normal appearance of the tramline sign correlates with a placenta previa but not a crepa, while a partial interruption corresponded to a case of placenta increta on pathology report, while the complete interruption of the tramline-like appearance of the uterine to bladder mucosa interface corresponded to a postnatal diagnosis of placenta percreta, which means deeply invading placenta. Following the previous study in which we reported on the correlation between the tramline sign and intraoperative findings or pathology reports, we continued our research activity in the field by evaluating the correlation between the tramline sign and perioperative outcomes in women with anterior placenta previa. These are the results from a two-center prospective study, including 65 women prospectively evaluated, in which of whom 29 had a normal tramline sign and the remaining had a partially or fully obliterated tramline sign, which basically means an abnormal tramline sign. And as you can see from the results, women with an abnormal tramline sign had on average a higher estimated blood loss, longer operative time, longer admission in the postpartum period. All but one case had hysterectomy, and the remaining case had actually a placenta left in situ. And of course, as you can see also, in respect to the postnatal ascertainment of placenta creta spectrum, you can see that basically an abnormal tramline sign strongly correlated with the finding of placenta praecreta in creta, or at least a creta with no cases of placenta previa but not a creta. I have just a couple of minutes left for my talk, and in the absence of guidelines reporting on how to image women at risk for abnormal invasive placenta, I'm going to show you how we manage a clinical case in our clinical practice. This was a 33-year-old woman, para 2, with 2 previous lower segment cesarean sections in uncomplicated pregnancies, who was referred at 20 weeks due to low-lying posterior placenta and unilateral renal genesis, which was eventually complete. This is the imaging at 20 weeks. You can see clearly low-lying posterior placenta covering the internal os with actually an interplacental lacuna. You can see the regular shape, you can see the flow even with the 2D grayscale ultrasound imaging. And let's see the follow-up scan at 34 weeks. This is transabdominal views where you can see a difficult imaging actually of the uterine bladder interface, but as you can see here, the interface looks a little bit irregular in correspondence of the intraplacental lacuna. And this is a transvaginal view with the power Doppler. Looking at the vascularity, you can see the vascularity is increased, but not so much, and particularly didn't look so much abnormal here at the uterine to bladder interface, and particularly looking at the uterine bladder interface, which looked a little bit abnormal or suspicious on transabdominal scan. You can see that here is pretty much regular. I hope you are with that. And then we have experience on the tramline sign, and we decided to get 3D volume transvaginally and to investigate this in a multiplanar view with render view with, as you can see here, the thin slice. And this was the imaging with crystal view showing the tramline sign, which actually appeared very normal here on the mid-sagittal view, while moving towards the right of this uterine to bladder interface looked a little bit abnormal in this point. As you can see, it looks partially interrupted here. And so on this basis, we had discordant findings, some suspicious of abnormal invasive placentas, other who are more reassuring. We decided on a MDT to from an MRI scan, which showed clearly here a deeply invading placenta here laterally. So basically the uterine to bladder interface was slightly abnormal here, because at this point you can see nicely here that was just the beginning of the deeply invading placenta, which basically deeply invaded laterally. And so this woman, of course, underwent cesarean sections with planned hysterectomy, so cesarean hysterectomy. This is the specimen. You can see here the cervix, and this was basically the deeply invading placenta. The uterus was removed and blocked. This deeply invading placenta here is an anterior view. This is the right hand side. This is the left on a posterior view. You can see here it looked like the fibroid, while actually this was the deeply invading placenta. And here again, these were postlateral views where you can see here the cervix here, and here the deeply invading placenta laterally on the right hand side. So my time is over. Before I finish, let me thank all these people for their clinical and research collaboration over the last few years. Of course, I want to thank you all for your attention.
Andrea, that was a fantastic overview of the imaging, which is brilliant, and obviously you spoke quite a lot about our methodology of looking at the uterine serosa and the bladder mucosa using those 3D reconstructive techniques. perhaps we'll talk a little bit about that if there are any questions specifically on the imaging. I don't think there are any. There is one question, I think, on the recommended time of screening, which I take to mean screening for placenta accreta per accreta. So we'll normally see a woman at 24 weeks and come to a pretty clear diagnosis at that point, and then repeat a scan at 28 and then 32 weeks. It's very rare that we change the diagnosis at 28 or 32 weeks, having made a diagnosis of between 20 and 24 weeks. Good. Okay. I don't think there are any further questions on the imaging. We may, I think Samsung have got a short how to do video, about 3 or 4 minutes, which we possibly show towards the end. But in the meantime, we're going to move toward another surgical talk. I hope Joseph will be able to share his slides. Joseph, there is a share button, and Samsung should have given you permission to share the slides. You're going to give a talk on the surgical approaches for placenta accreta spectrum. What I'm going to do is, immediately after Joseph's talk, I'm going to also give a short talk of about 5 minutes, 4 or 5 minutes, on the delivery approaches. So we often think a lot about the gynecological approaches to managing hemorrhage, internal artery ligation, if that's what we like, aortic clamping, interventional radiology. But I do want to say a few words about delivery of the baby, because in my experience, that's not often talked about, and you can get into a bit of difficulty if you don't think very carefully about how to deliver the baby in the first place. So I'm going to hand over to Joseph Yazbek. Joseph is my very good colleague here at Imperial. He's a consultant gynecological oncologist, but he's also interested in obstetrics, which is wonderful, because that means I can pull him to the labour ward, and we operate together when these cases come up, and he will also counsel many of these women. So Joseph, without further ado, please talk to us about surgical approaches for placenta accreta spectrum, and then I'll follow that with a brief talk about delivery, rather than interrupt in the middle of your talk.
Thank you, Christoph. I hope you can hear me very well. Can you?
Yeah, we can hear you perfectly.
Okay, so I'm just going to present my lecture live, and thanks to all the team in Samsung who made this possible, because we had problems with our recording, and we feel it's better to deliver the lecture complete rather than have interruptions in it. It does give me a great pleasure to present this shared lecture with Professor Lees, who we work very closely together at Imperial College. And I'll be talking to you about the surgical approach for placenta accreta spectrum. As you've heard from the many lectures earlier today, you may be under the impression that placenta accreta spectrum is a consequence of cesarean delivery. I mean, it's not false, but there are many other factors that could lead to placenta accreta spectrum with any procedure that breaches the interface between the endometrium and the myometrium, including resection of polyps, removing fibroids, or removing retained placentas. All these could contribute to the placenta accreta spectrum, but this is not a result of one surgery. We have multiple factors that are presenting here and making us very challenged on labor ward when we are delivering a woman with suspected placenta accreta, including the rising maternal age, and quite a few of these women have had multiple surgical issues. And the improvement in assisted reproductive technology has led to improvement in pregnancy rate, and therefore we have this problem. Of course, in up to 90% of confirmed cases, hysterectomy is a life-saving procedure, and you should be very ready to do such an operation. But this surgical complexity is not usually when you deliver the placenta, is mostly from the start to the finish. And you have to be ready to make decisions all the time, and you have to make the right decision. Otherwise, the patient could be compromised. So you have to plan the safe delivery, and that is the most important part of managing placenta accreta spectrum. You have to anticipate the problem while ahead, including the amount of bleeding that you're going to lose, the amount of adhesions that you might be facing, and of course there are other organs that may be involved in the operation that could be affected by your delivery. You may have to mobilize these organs, you may have to repair these organs as well if you feel that they've been damaged. Of course, this is quite basic what I'm doing here. There are 3 types of incisions. The majority of people might go for a midline because this seems to be the way that we could go and expose the abdomen very well. But I will probably concentrate on the phalansteal and malar incision, which both are low transverse incisions. And I'm going to show you a very quick video. I hope you can see it very well with me. Both of them are low transverse incisions. The difference between phalansteal and malar is the exposure of the abdomen. As you can see here, we're opening the lower part of the abdomen. We open the rectus sheath and we reflect the rectus muscle off that sheath. Basically, we open the peritoneum and we allow ourselves enough space to enter the abdomen and be able to deliver a baby or a uterus throughout. Whilst the malar incision is the same principle here, we are cutting the lower part of the lower abdomen, so it's low transverse incision. The difference here is that we are transecting the rectus muscle, as you could see here. That will give us a great exposure of the lower abdomen. The only difference between the midline and malar is that a midline you can reach the upper abdomen. Make sure that you ligate the internal iliac vessels. As you could see here, we carefully dissect them, cut them, and then tie them. But as I said, this will allow you to do lots of surgery in the pelvis. I don't think many people will think about it because they think midline will give them better exposure. Look, this is not a cesarean section, but look at this huge uterus that we are delivering through this low transverse scar incision.
Joseph, can I just interrupt for 1 second? And that is, I think you said by accident internal iliac.
Sorry, no, sorry, no, sorry, no, sorry.
On the obsession, so inferior epigastric.
Inferior epigastric, I'm so sorry. Thanks, Christoph. There are 2 aspects to placenta accreta spectrum. How you plan the delivery and how you think about bleeding. Because bleeding, you need to plan it before the operation, how you're going to control the bleeding, and you have to think about it intraoperatively. There has been discussion about the use of prophylactic balloon occlusions, and this is widely used in the UK or in units where there's no surgical access to occlusion of vessels. This has to be done before the operation. The occlusion could be for the abdominal aorta, common iliac, internal iliac or uterine artery. However, the evidence is conflicting. There has been quite a few complications, severe complications in the insertion of balloons, and they are not readily available in cases of emergency. Embolization is the same issue here. It's good in controlling bleeding, but you cannot basically use it when you have heavy blood loss on the table and you have to do a hysterectomy. The general principles of intraoperative care is to not disturb the placenta, to try to do vascular occlusion by clipping or internal occlusion, control the placental area or deliver the placental area that is adherent, do a hysterectomy or put a pack. I think Christoph wants to do his bit at the end. Is that true, Christoph? And then I'll carry on. So I'm going to just talk to you about vascular devascularization or the internal iliac artery occlusion. And what we do is very simple. We open the pelvic sidewall, as you could see in this picture here. And the pelvic sidewalls in a pregnant woman are not different from non-pregnant patients. You could see here the ureter, and I am dissecting over the internal iliac artery, making sure that I identify it very well from the external iliac. So I do that several times. You have to have good exposure, and once we are sure about that, we use a bulldog clamp, what we call vascostat, that does not traumatize the vessel, and you apply it over the internal iliac artery bilaterally. This will significantly reduce the blood supply to the lower abdomen, to the pelvis mainly. This is safe and easy to do. It takes about, as you've seen it here, it's not sped up. It takes about 3 to 5 minutes to do on each side, but it will basically help a great deal in your surgery. And from this slide, you could see our blood loss before and after the use of vascostat. Our blood loss used to vary between 11 liters to 6 liters. This 500 mils of blood loss was in the case of a placenta that was left in situ and the uterus was closed, so we didn't use any vascostat. Whilst with the use of vascostat, we started noticing that our blood supply was quite manageable, around 2 to 3 liters. The beauty of devascularization is not only that you could have less blood loss, but you could also allow yourself to do preservation of the uterus. In certain women who do not want to lose their uterus, as in this lady's case, the placenta was attached to a very small defect in the lower segment. You can see we delivered the baby via a midline incision. Took the placenta from that defect area and excised it whilst we have the vascostat in situ. And then we basically repair the uterus with monofilament sutures using 3O PDS. This gave this patient obviously a uterus that probably could have another pregnancy in it. As I said initially, it's not only about doing a hysterectomy, it's about planning the procedure, like in this lady's case who had a multiple bowel resection. And you can see when you enter, it took us about 2 hours to start seeing where the uterus could be. And as you can see here, there's a thick layer of the peritoneum that we have opened up and identified where the uterus is. So it's so important to have good exposure, because otherwise there's no way you can deliver the baby safely. But we cannot do a hysterectomy safely, actually, if you have a very small incision that you've made in the abdomen and you're struggling throughout it. And remember there are other organs that will be involved in as you see here, the bladder was opened, whether we call it orientation, cystotomy, or an injury, but we identified it clearly during the same procedure, and we repaired it using 2 layers of 3O Vicryl, and it's all fine at the end of the procedure. I like this slide because it shows what you should be as an expert. You should always aim to have people who do placenta accreta to be in the unconscious competence. They have to really not think about the next step. They have to do the right thing without thinking too much. It has to be an unconditional reflex reaction in order to achieve the best care for these patients. Very briefly, we have a core team which involves a gynecologist and an obstetrician fetal medicine specialist, as well as an anesthetist. But you have the wider team, including urologists, colorectal specialists, vascular specialists, and interventional radiologists. We discuss these cases in a multidisciplinary team on a regular basis when we are planning delivery. But of course, the approach starts not only when you see the patient. You have to start from the referrer to making the diagnosis before you go and just plan your delivery and start talking about vascular occlusion or taking the uterus out. So to sum up, the surgery involves a gynecologist opening up the abdomen, an obstetrician delivering the baby. We will check whether the placenta will separate or not. Otherwise, it's left in situ, the uterus is closed, and the pelvic side walls are opened and vascular stents are applied on the internal eye leg arteries, and we do a hysterectomy in 90% of cases of placenta accreta spectrum. This is a sample of the team that we have, and probably you could see both of us on the screen. And don't forget the importance of your anesthetist. You have to have an anesthetist that is replacing the blood loss. Without replacing blood, the patient will start going into DIC, and you will run into problems surgically. So it's very good to have so many blood bags on the floor, but not to have so much blood on the floor itself. Thank you so much.
Joseph, that was a great talk. We're getting some very interesting questions in. I've just seen Jose Palacios Giacomedo is joining us as well with questions, so we'll answer some of those at the end. So that's fantastic. I'm going to just talk a little bit about delivery, and then we will talk about then we'll answer some of the questions and talk about some of these surgical approaches and go through some of these very interesting questions. Now, I'm going to hopefully share my screen, and I'm going to go to PowerPoint. So I'm very much hoping that you can see my PowerPoint. Can you?
Yeah.
Fantastic. Good. Okay. So I'm going to spend about 4 or 5 minutes talking about delivery of the baby. And what I'm going to say is based on personal experience and discussion with colleagues, and I'm going to invite the audience to give their views afterwards as well. And with placenta accreta, increta, percreta, the baby is very frequently in a transverse oblique position and is often quite difficult to deliver. So I think it's important to realize that with a thick lower segment from often a premature delivery, 34, 35 weeks, delivery can be difficult. And the key to this is that an incision, in my view, has to miss the placenta while giving sufficient access to safely deliver the baby. I take a view that I never ever want to cut through the placenta, because cutting through the placenta will always cause bleeding, and it's almost always possible to avoid it. And to avoid it, you need to have done a scan beforehand, and either you or someone needs to have scanned for you on the operating table before you are about to do your skin incision, in my view. Now, if the placenta is posterior or very low central covering the cervix, you can often do a high lower segment incision, and you won't go anywhere near the placenta and be able to deliver the baby through that. If it's an anterior previa, anterior major previa, then you often don't have the space to do a high lower segment incision. You just might, but you can only decide that by a scan prior to. So I will, in those cases, always do a classical incision right to the fundus of the uterus, and you all know what a classical incision looks like as opposed to a transverse uterine incision. So let's talk about a couple of cases. This woman was 33 years old, para 1, previous cesarean section. Look at the 2D imaging there. Say not convincing for placenta accreta, increta, percreta. But if we look at the crystal view image, can you see on the bottom image there, there's what we call the tram lines, and towards the bottom of the tram lines, you can see that internal tram line, which is the myometrium, a little bit blurred. This is where the placenta does seem to attach partially to the scar. It was just a very small area, and we thought this was a localized area of accreta. So we stayed on the fence when we were talking to this woman about whether a hysterectomy would or would not be required, because it was possible that the vast majority of the placenta would deliver itself. We electively delivered at 36 weeks, and you can see that image there. That's me or Joseph's fingers swabbing, and there's just above the cervix in the lower segment, there is an area, slightly ragged area, where although the placenta had extruded itself, there was still a ragged area. And there are irregular bumps as well. This woman had endometriosis, and we thought that there was decidualized endometriotic tissue. So there was a small raw area of a couple of centimeters diameter that was easily oversewn. I think Joseph oversewed it, and there was a thin lower segment, but there was a good closure and the uterus was well contracted. Let's look at a different case here. This is a case where I'm sure many of you will recognize immediately that there are lacunae in the placenta. There's absence of the retroperitoneal space. The vascularity is really all over the place and very, very close to the bladder mucosa. If we just look at this in crystal view, and this was a very interesting case because she had had a hemoperitoneum at another center, a very good local hospital, and they noticed a hemoperitoneum. They opened her up and did a laparotomy and managed to put some stitches in some vascular tissue. And in fact, we never quite worked out what the vascular tissue was, but we think it was probably serosal vessels that were bleeding due to a distended scar. So anyway, it was brave, but she came to us. She stayed in as a hospital inpatient. The MRI suggested placenta percreta, but on the crystal view, we thought this was actually increta accreta, and delivered her at 27 weeks after a major antepartum hemorrhage. And you can see from this specimen what happened. She had a hysterectomy. I just want to show you a few points on that hysterectomy. She had a high fundal classical incision to avoid the placenta, and the cord and placenta retained in situ, and the incision was closed up to do the hysterectomy. And the histopathology was placenta increta, in fact, not percreta. So just showed you we had an MRI diagnosis of placenta percreta, but ultrasound, we're pretty sure it was increta. So that is all I want to say really on delivery, and I'm going to stop sharing now. And I think what we'll do is we will go back to let me just try and get back to the right view on WebEx, which is not always easy. Don't seem to be able to do it. Can I stop sharing? There we are. Yeah, excellent. So let me stop sharing. And I think what we can do now is have a little discussion and take some of the questions. So I'm just going to take, we've got Rosie, we've got Joseph, we've got Maya, and we've got Professor Bourne. So we can just go through some of these questions. Welcome.
Could we start at the beginning, yes, sort of chronologically, because rather than, and we can end up at the surgery. But there is one question, only one question actually, from sort of early pregnancy, which I just want to cover, and that's this issue of whether women who have had a previous section should have a scan. There's a comment in the chat. Many are missed at EPOW, and routine first trimester scans don't always report the implanting site. It's only picked up after the 20-week scan. Should this be made routine in all mums with a previous cesarean? And of course, this is basically screening. And I personally have big concerns about screening in early pregnancy because we don't know diagnostic test performance. We don't know the false positive rate, which has obvious potential major consequences in early pregnancy. And which is why we need good diagnostic test studies very urgently. But that's my view. May, I don't know what your view, and I'd just be interested in May's view from an early pregnancy perspective, and then Christoph, what your position would be about looking at the time of the 11 to 14 week scan, for example, if that was feasible. May
I mean, we tend to look at in our unit the implantation site, so it's something we do routinely, but with the big caveat that you have to take your time before making the diagnosis. And actually, the Jackie Ross prospective data made a very good point that most of the diagnoses was confirmed later in pregnancy, from 8 weeks onwards, where you can be a little bit more sure about the placentation and implantation site, which I think is reasonable. I'm not sure about routine screening. That kind of has its own, controversies, and I don't know what you think, Professor Lees, about 11 to 12 weeks routinely looking. Although I do think it would be very useful and would probably be a very good time to be looking at placentas.
Well, I mean, screening, as WHO has very clear criteria for screening. One of which is the performance. The performance of the diagnostic test you're carrying out. I mean, I think that this problem does fulfill other parts of the WHO criteria. It's an important clinical problem. Diagnosis could alter the outcome. So a number of those things could be ticked, but you need to know, we need good diagnostic test studies. Christoph, 11 to 14 weeks, should everyone be looking at all previous sections and paying a bit more attention?
Okay, so we, as you know, we get some very interesting diagnoses from you and Maya and the early pregnancy team in women where there's a concern about scar pregnancy. I have to say, I almost always wait until about 16 to 18 weeks because the placenta at 11 or 12 weeks is developing rapidly, and personally, I don't think you can have a good idea about where it's going to end up. Well, 16 weeks is certainly very early still, but at least you know if it's anterior, posterior, and you can sometimes see if it's fundal. So I might see them at 12 or 13 weeks, but I would then normally wait until at least 16 to 18 before being any more definitive.
Can I just bring in Rosie about what happens in Indonesia? I mean, we're sitting, in London and going, whatever. Do you find quite late diagnoses, or is the system of antenatal ultrasound very, very well organised where you're practicing? How does it work with you?
Actually, usually the patient will come to us in the pregnancy, and some of them become vaginal bleeding. So, usually they refer to our outpatient clinic in the 3rd trimester, but now the 1st trimester patient, we already some of them in the 1st trimester. So we use the Prof. Ilanti Mortrit strategies. We see the gestational sac in the niche or in the scar, so we can predict, and we follow the placental development, and we inform to the patient the prognosis become the procreta or advanced grading. So we inform the patient maybe it's better to get the terminate the pregnancy to give a chance the patient to get pregnant again, and we usually do the surgical management.
Okay.
Yeah. Good. Let's move on to, I'm going to move on to some of the later, I think we're moving chronologically now towards the 24-week scan, and I'm going to take Dr. Palacios Jarcomeda's question, which is a really interesting one. How many patients need to be scanned to be an expert in PAS diagnosis? And I don't think we can answer that because there isn't actually a definition of an expert. I mean, I do a lot of this image. Andrea does a lot of this imaging. Many people around the world do a lot of this imaging. What constitutes an expert? What I will say is that I think it's absolutely critical to publish results of diagnostic imaging. So if we are talking about imaging and new techniques, then once you publish it and put that out there for review and others to look at, then that's important because that stimulates discussion and constructive criticism. Rosie, what do you have a view on that? And I don't think any of us would be arrogant enough to say we're the ultimate experts in imaging. What do you think of that view?
Okay, so in my experience about the ultrasound, yeah.
Yeah.
Okay. Actually, I use the same technique that you did. You use the crystal view. I use that too, and I think the other majority is not only one sign but also a lot of sign, which is usually if there is more than 3 signs, usually they will become the placenta creta. And the strategy for the referral patient, sometimes it will difficult to to teach all the OBGYN in Indonesia to know about how to diagnose it. So we use the marker as the placenta previa. They have to refer to our patient and our patient clinic, and usually we did the ultrasound maybe 5 cases with the placenta previa with previous cesarean section, and usually we diagnosis maybe 1 until 4 cases a week of the placenta creta spectrum. So we have a very high number about that.
Yeah. Okay. Good. And there's a follow-on question from that. To have a second opinion diagnosis of PAS, is it necessary to refer the patient, or can you evaluate a specific recorded scan? And of course, because we do a lot of 3D post-processing imaging, you can just look at a 3D volume. But what I would say there is that many of our women, we fill the bladders, empty the bladders, fill the bladders, get them walking around, do TV, do transabdominal. So it's not just a 20-minute or 30-minute scan. So I personally, I think I would only be comfortable seeing someone in person. Rosie, would you agree with that?
Yes, I agree, because because the placental mapping, we call it placental mapping, it's will take time, because we have to wait the bladder wistfully, and now we routinely do the transvaginal ultrasound to make sure the cervical invasion too.
Yeah. Okay. There's a question here about conservative management of placenta accreta. Well, conservative management is either leaving the placenta in situ, or it's the excision technique. Rosie, that's a question to, well, that's a question to you. Conservative management of placenta accreta.
Okay, thank you. We never do the left placental in situ. So all the patient, maybe about the in the last 3 years, we have about the 85% we uterine resective conservative surgery in all placental grading. Even for the bladder invasion, we have a special technique to how to manage, how to conserve the uterus even if the placenta was invaded to the bladder. Because the important thing is the lower bladder invasion.
Yeah, I think what we really do need actually is a proper prospective study, don't we? I mean, we need people who are working together. So, for instance, we work together with Professor Kelly in Italy, Andrea Del Asta, and others in Parma. There are many very good units. Yours, there's Argentina, there, Oxford in the UK, St George's. We actually, someone needs to do a prospective study, don't they, of conservative versus hysterectomy. Joseph, do you have any views on that, on this? Of course, every center will have its own particular expertise and interest in different surgical techniques.
I mean, just doing conservative surgical management is quite challenging, especially when you have a proper placenta accreta or percreta invading bladder and going everywhere. All what you care about is actually saving this patient's life, not saving her uterus. But of course, I think that there are selected cases that you can tackle by localizing the placental site and reconstructing the uterus. I don't think it could be applied generally to every woman. It is a case by case probably selection and discussion before the surgery.
Yeah. Okay. And should we talk on that note, talking about surgical techniques? Should we just talk about internal artery ligation? So, Rosie, you said there were some dangers from internal artery ligation. Did you mean by suturing or by interventional radiology? What is your experience with internal artery ligation?
Okay, about the internal artery ligation, because we difficult to get the balloon, so we prefer to do by hand. So, and the all time we routinely do the internal iliac artery ligation after the communal iliac, and then they branch to the external and the internal, and we about the 3 centimeters we usually ligate in that place. And we have maybe about the 3 cases with the vascular injury. So because I remember one of them because of deep infiltrating endometriosis, and it became disaster, and that's why we have experience with we already ligate the internal iliac artery ligation, and we do resect the placental invasion, and there is massive bleeding from the placental bed in the cervical area. So we focusing in the vessel ligation from the vaginal artery and vesical artery to reduce the blood.
Yeah. I mean, I think what comes through loud and clear is that you've got to be really interested in this and well organized. So, for instance, in the UK, I know this isn't a UK centric webinar because we have many attendees for internationally, but the organization of placenta accreta is being consolidated around a few regions. So for Northwest London, Imperial and Chelsea and Westminster working very closely together to provide a service which throughout the UK will mean increased numbers and keep the surgical expertise in not spread absolutely everywhere, but spread among those services that can resource them. So it sounds very similar to what you're doing, Rosie, in Indonesia, but in a slightly different way, I suppose. Jose has given us another point to say there's a prospective study comparing hysterectomy and local resection, which is interesting. So I didn't know that. That would be very interesting. I look forward to hearing more details on that. Good. Okay, I'm just looking through. Tom, can you see any other questions or any burning questions that I have missed? Tom, Mayor, any comments?
Not so much in a sort of early pregnancy.
Professor,
there is this question. Sorry, I do apologise, Mayor. I mean, can we just touch? There's a few questions. I think it came up before. This idea of repairing niche. I know it's not immediately relevant to the whole delivery area, but I know that Joseph, you've done a couple, or you've done a few, haven't you? Not a huge number. I don't know about yourself, Rosie. I mean, there's another comment here about VBAC, which I have to say, I mean, I don't do obstetrics anymore, but I'd run a mile from a VBAC and a person who'd had a niche repaired after a section scar pregnancy. But and I think Christoph was of a similar view. I think no one in the panel seems to be nodding their head or disagreeing with me. So I think we'll just leave that one and park it, shall we? Mayor, go on. Sorry, I interrupted you.
No, I was going to say, Prof. Lees, there's some questions about how you can learn to do the crystal view techniques.
Okay, right. Now we've got, I don't know if Samsung have got, we did record a little how to do that for about 4 or 5 minutes. And this showed the different controls and how we orientated the volume and how we analyzed it. I don't know if it's ready, actually. I don't know if it's available for tonight. Perhaps June or Joseph or Rachel could tell us. I suspect it isn't, but if it is, just let me know, because we could possibly play that. So the answer to that is that we are preparing how to do techniques, and it's not a terribly complicated technique, and we're just writing it up how to do it at the moment. Anyone from Samsung, can you tell me if we have?
Hi, this is June here. The video is not ready yet. It'll probably take us about a week. There's some minor adjustments that we need to make, or reshoot some of these screens, but by the end of next week, we should have things ready.
Okay, so if there's interest in seeing this video, can we send a link to anyone who's joining us here at this webinar to that video, June? Because
yes, we can do that.
I think it would be quite important for people to see it. It's one thing having a technique, and we love it, and we think we get good images, and Callie in Sicily thinks it does get very good images, and Andrea does. So those that have developed, and Rosie I'm sure does as well. But you know, we want to teach it. We want other people to know how to use this technique as well. So, June, I look forward very much to hearing from you when that video is ready, and we'd like to review it and then get it out there so that everyone can see it.
So, Christoph, I think we probably dealt with most of the questions, and I know we're running late. So my feeling is we probably should draw things to a close, if you would agree. Any other burning issues or comments from the panel? Joseph, Rosie, everyone happy?
No, it's great.
I like your paintings in the background, Joseph. Very nice.
Thank you.
They look like pictures by someone called Ali Peary, but I don't know if that's right. But,
it's not.
No, never mind. Anyway, Rosie, I saw a number of electric guitars in the background when I saw you earlier, and you promised that you were going to play us out.
Really not.
So there's no. So for the next webinar, Rosie, I expect some serious guitar music. Okay.
Okay.
Okay, man. So I think Christoph, I think we better close. I think it's been a great webinar, and it's really good to have a topic that anyone in Obs and Gynae can get something out of. I think this is a hot topic, and there's a lot of research that needs to be done, really. I want to thank all of our speakers, starting off with George Condis, if he's awake over in Australia. And it's great. I think the concept of this sort of East versus West has worked really well. Mayor, thanks again for all your work and for your talk, and remarkable control of your young son, who hasn't made any noise at all. So I'm sure, I don't know what you've done with him, but I can't hear him. So that's a fantastic performance. Rosie, it's been a pleasure to have you. I've been wanting to get you involved in the meeting since we met in Singapore, and I mean what you've done in Indonesia and your huge experience in the field is fantastic, and hope to see more of you in meetings. I'm so sorry with COVID that we can't travel. It'd be great to see you in person, but you will be made to play the guitar, so bad luck. That's definitely going to happen. And also thanks, Joseph. It's fantastic. Christoph, I think you'll probably want to say a few words. I'd like to thank Samsung for sponsoring and helping put this on, and also to Imperial Consultants as well, who've done a great job in putting these together. It's another one of the series, so there will be further webinars each month, so look out for them, covering further topics in obstetrics and gynecology. Christoph, I'll leave the last word or words to you.
Well, you said it extremely eloquently as ever, Tom. I've enjoyed this webinar. It's great fun. It's a shame we haven't had longer to discuss the surgical aspects. I just wanted to one final question, which I'm not going to answer, but someone's asked if Crystal View does increase PAS diagnosis, or does it just provide pretty images? So thank you very much for that question. I'm hoping, I seriously, a lot of 3D techniques, you show these beautiful images and then you think, I can't recreate them. Well, believe it or not, we do recreate them. We have a placenta clinic every week, and we have lots and lots of volumes every time. But it's up to us now, having described this, to show you that it works. And that's where I hope Samsung are going to get that video ready. So thank you very much, everyone.
Can I, Tom,
you have the last word.
No, of course. There's a question here. Will this webinar be available on demand to people who have been, and I think that's quite important to know, if people can go back to this webinar and listen to it again who've been here. Come in Samsung. Is that happening?
So we will have the links available to the people who have registered for the webinar for the next 2 weeks, and we'll be sending out another email tomorrow morning with a link that will be open for 2 weeks.
I honestly, I'd make it try and make it a bit longer. That's quite a short time. People on holidays, I think you should keep. I would argue they should have it open for a month, because people don't have a lot of time. But you can decide. So I think that was Suzanne Johnson. Hopefully that will enable you to watch the webinar. So I think that is the last word. Christoph, thanks to everybody. Hope it's been a good webinar. I hope you've enjoyed it, everybody who's been watching around the world. And I hope to see you for the next webinar, and see you all soon. Thanks very much.
Thanks. Thank you.
Bye.
Bye. Bye.
Bye. Thank you.
Yeah.